Hopefully you are seeing a full screen right now, and I'm going to click through it. Okay. So as you can see here, I've said continued work, and work is in italics, equals better overall quality of life. And work is paid work, is unpaid work, is volunteer work, and is occupation as a whole. We tend to think as work as employment based, and it's really important for financial security and health related quality of life. And that's a big study, and that was undertaken by a whole group of HD boffins in 2010. And the other thing that I draw your attention to here is that education and occupational attainment builds cognitive reserve. So what we do know from HD research is that continuing to take part in work, continuing to take part in education builds what's called almost like a reserve, which in other words means almost like acts as a, not quite an antidote to the disease, but actually builds strength against the developing disease at a neurological level. And that's what we know to be true. So when we think about work and we think about the importance of work, that's what we need to think about. But there's a big but here. In HD, we have to recognize that the effort required to remain in work is huge, not just from a social perspective, but also from a cognitive perspective, an emotional perspective, and a physical perspective. And whilst the drivers in UK society are about everyone's got to remain in work, of, you know, adults of working age, I think as occupational therapists, we have to remain sensitive to this particular thing, that actually, it might actually be a relief for some people to stop working. And there's that sort of sensitive space in between that we have to advocate for. So yeah, absolutely. If the person's goals are to remain in work, of course we should be working with them. But sometimes there comes a point where we're actually going to have conversations which say, actually, is this appropriate anymore? And I've known people say, phew, thank goodness for that. But we have to allow them to guide us. We have to have conversations with families, with companions, and with employers as well. Kind of leads me to the next point. People may not want their illness made clear to their employers because of fear of discrimination. And we're going to talk about that throughout this presentation. So I do work with people who don't want their employers to know. And that can be a really difficult spot for us, because actually there is legislation that hopefully protects them from discrimination, but people are still really frightened of discrimination anyway. And then the other thing here is that people may not attribute their work function changes to the illness. And in many cases, you know, it might very well be that their work function changes might not be due to their Huntington's disease, because not everything is HD. However, sometimes things are due to HD and people might lack the insight into that. And we have to sensitively guide them through that if they'll allow us to. So I think I've seen like 3 little questions popping up at the top, but I'm not too sure.
It's just about the webinars and when they can be accessed, Alex.
Okay, cool. So I'll go on to the next one. So changes in work function. I've just said they might not be due to Huntington's disease, and they might not, and we need to be open to that. However, if we're thinking specifically about Huntington's disease, this is why that might be the case. Cognition changes, behavioral changes, mood, mobility, movement, sensory changes, and by that I mean more sensitivity to heat, light, noise, being overwhelmed, and physical and emotional fatigue. Now this is a very similar list to what Kirsty and I have spoken about in other changes throughout the webinars, but the same still applies in HD. that all of these things affect functioning, and we need to be open to that. We're talking about adults of working age. So when do those things that I've just spoken about start to impact the person, and in which case will it affect their working lives? And the answer kind of is yes. So this is again a slide from an academic study, but what I kind of want you to notice is that actually the lines gently sort of pulling away towards my right hand side of the slide. So you can see that at about underneath there's a little line that says 5 years, and that's 5 years from the motor symptoms, the classic symptoms of HD coming into play. And you can see that processing of information, concentration, and also executive functioning, so that's the ability to pull loads of information together, starts to decline quite quickly. And of course, those are the skills that we really, really require to keep working. And actually, folk with HD, their brains are working really, really hard. I think we've said this, you know, time and time again. For us at work, gosh, multitasking is really, really hard. And Kirsty's just taken on a new job, and she was saying how difficult it is for her right now. But actually, for folk with HD, they're running many, many marathons a day in order to keep up with everybody else, in order to present well at work.
Alex, we've got a question which I'm going to just bring in now so we don't forget them. From someone who's listening today. I told my employee manager about my HD. When I had my test come back positive, do you think this was the right decision?
Okay. Yes, I do. Okay, no. First of all, let me say, it really does depend on your contract and your status of employment with them, and also how you feel, your gut feel about your employer. If you feel that they are a good employer, yes, I think it's the right thing to do, because now you've told them you are protected under legislation, discrimination legislation, and it also requires your employer to make reasonable adjustments to accommodate some of the symptoms that you might experience as time goes along. So in an ideal situation, yes, I think you've done the right thing. Okay, so this is getting back to all our occupational therapy colleagues and other healthcare professional colleagues out there. But again, if you're a person with HD or you're a family member, you might want to know what the heck is done in order to try and work out what's going on for the individual with their employment. Okay, so this is about assessment. And so there are tools which are used by therapists to describe what might be happening for that person once they have been referred to a professional. And they're very much their work scales. So one of them is the World Health Organization Occupational Functioning Scale. And essentially it means it's a record of work at that particular time. So an OT comes in and they have a little look and they have a little conversation with you about what's happening for you at work. And it kind of quantifies what's going on for you, and it acts as a baseline. So then from there, if there's any deterioration, you can work out what's happened over time, but you can also say, actually, these are the areas that you or your employer needs to look at in order to enable you to return to work, in order to enable you to continue at work, and again, act as that record. Okay, so you can imagine we kind of just need to know that, because otherwise if we say, well, this and this and this and this is going on, it's not an adequate record, it's not fair to anybody. So there are a number of tools that the professional can use. And this session is not about that. This session is more a general overview. I think in our clinical tips for OTs, which is available on the HDA website, we looked at a tool which was called the Model of Human Occupation, and the assessment tools there. Again, those can be used as a starting point. For me, they're not valid and reliable enough. So what I've recommended here is that there's an add-on, which is called the HD Work Function Scale. And this came from a group of HD boffins who interviewed people and their families about what was happening for them at work. And they put this tiny little scale together, which is something like 3 or 4 questions, it's not very much, about the early warning signs at work when things are going a little bit difficult for folk with HD. And the other work function scales are fine. They're fine for musculoskeletal conditions, other types of conditions such as pain, but they're not HD specific. So if you're a practitioner, we'd recommend that you just have a little look at this. And if you guys want the links, then again, either email me or Kirsty or get on our OT hub or whatever you want to do. I think we're fairly easy to find, and just let us know, we can guide you that way. But anyway, the little red flags for people were actually wanting to be isolated at work, not necessarily wanting to engage with your colleagues anymore, finding the working environment overwhelming. Telephoning was quite difficult for people as communication and language changes. So there were just 3 key areas that are little red flags. Okay, let's raise that right now. What can we do about them? What adjustments can we make to help you continue working for as long as you might wish to work? And then we've got to factor in risk assessment, because some of those things that I've spoken about they're quite low risk, they're low grade risk, but actually some folk with HD have quite profound movement problems or mobility problems, because everyone with HD is different. There's some commonalities, but there are some similarities, but there are some differences too. And it might very well be that you could be in your early stages, but you're operating heavy machinery. And actually, we need to take the risk into consideration as well at that point. And that's where employers tend to get a little bit nervous. And that's where they might want to make reasonable adjustments, because clearly, if you are an operator of heavy machinery and you have a movement problem, say the risk is risk of entrapment or injury, of course, they have a duty to make sure that their employees are safe. So it's not just about occupational legislation, it's not just about discriminatory legislation, it's also about work legislation. And that's why they might talk about, hold on a second, your skills and the risks and everything else aren't quite balancing up, and we think the risks are too great. What are we going to do about it?
And I was just going to add there, Alex, in terms of assessment, if someone is not engaging or haven't got the insight into there is a problem with work, then the assessment part for the occupational therapist for sure doesn't even start. And I think about someone that I know in the local community who hasn't been able to hold down a job as Huntington's disease has progressed, but doesn't want to talk about that or discuss it, is determined to remain in work. So keeps going to interviews and getting different jobs, and they're becoming what's the word? There's no contract. Help me, Alex. What's the word? So it would be a bar work or cleaning work. So for this person, changing jobs became a factor because of the new routines and learning new systems. So in terms of admin type work was too much because of the changes and the cognitive components of learning something new. So for this person, looking at different kinds of jobs, and doesn't want to to talk about that, but it's determined to work. And I've got so much respect for that person because they want to carry on working.
They have, but you know, I suppose it depends on whether we're talking about doesn't want to talk about it and actually, you know, realizes it's a problem. That's different to sort of a lack of insight, isn't it?
Yes.
And therefore moving on because of a lack of insight and not quite understanding why every time she gets a job, she's actually fired for the job, or actually she has to leave the job. And it's not a perfect world by any stretch. So I'm talking about all of these things in an ideal world. But, you know, I've got a chappie whose employers wrote to me to say, actually, we'd like you to look at him at work because he's driving heavy machinery. And I did. But, you know, then he's now disengaged. He's kind of fallen out of the system. And I don't know why. It's because actually it's quite frightening. It's really frightening. And our job is not to trip people up either. That's the other thing. So I think we've spoken previously about this is all subject to that individual's presentation, to awareness, to insight, to risk, to capacity, to all kinds of things. So this is not easy. It's not easy for professionals. It's not easy for family members. It's not easy for folk with HD. That's the understatement of the century. So if in our ideal world you get to have those conversations and people don't leg it, and they want to have those conversations, the first thing, I suppose the first stage, if you like, is education. Is like, I've done this assessment of you, I've observed you, I've heard what you've said, but I've also seen what you're doing. Because let's face it, you know, actually with occupation, people are not only what they say, they're also what they do. And this is where I think we can make changes. And this is why I think we can make changes. And then at that point, you're kind of working out, all right, can they adopt those changes internally? Do they have those abilities to do that? Or actually, are we moving to the point where actually others have to make those changes on their behalf and, if you like, organize the structure of the environment so that they can continue? And again, there's that fine line in HD. It's probably a little bit of both because one reinforces the other. And then there's also, if the person will allow, and this is about consent, because I think lots of HD it's a family condition, I get it, and every conversations are often co-constructed, but as professionals we still have to get consent to talking to others, particularly about these sensitive issues. I've joked before that there's, you know, things in HD, there's sex, there's drugs, there's money, there's work. All of these things are really, really sensitive areas, but we still have to have people's consent to talk to companions and family. But we'd love to, of course we would, because everyone kind of reinforces what needs to happen. Then, if allowed, we can talk to employers, and we'll go and we'll talk to employers, and we can do that either with the person or separately from the person. And again, I've talked about consent here. And then that's about, okay, what do you know about HD? Do you know about the small changes that can be made? This is the treatment plan, etc., etc. But when I was writing this, I was thinking, you know, got a couple of folk who are self-employed. So I'm just gonna pick one particular, I suppose, person, employed as a mechanic, and was getting really fatigued, dropping things, injuring himself. And so we had the conversation. He was open to the conversation. I think he'd realized that, you know, it was a couple of years and probably he was going to have to wrap up his business. But, you know, he was just like, just one more go, one more turn. And I was just like, okay, but actually these are the ways that I think you need to alter stuff, having observed you, and to minimize the risk, because also you're married, you've got kids, you got other responsibilities. We've got to think about finances here. And so he listened and he changed his practice. And then we built in some fatigue management, and that happened throughout COVID, actually, last year, because he worked alone. No, sorry, the previous year. And he and then he's transitioned to retirement. And again, I know that's an ideal story, but it was about having a transparent conversation with him. We also had a conversation about money as well, because it's a scary point, you know, work equals income. But he and his family had planned ahead, and he had got a pension pot. So therefore, we didn't necessarily have to think about employment support allowance, because he's not at the traditional retirement age. And then, but we were able to get him PIP, for example. So again, work and money closely related. And if you're a professional working in this field, you have to consider all of those things. Kirsty, have we got more questions? Is there another?
No. Oh, have I missed? Unless I've missed one.
Looks like there's 6 up there now.
Oh. No. Not in the chat.
Okay.
No.
Okay. So, okay.
Question answers, no.
So after education, and don't forget, I've just chunked these into separate sections, but they're probably going on consecutively at the time, is actually, right, what we're going to do, adjustment. So let's think about this person having a job plan by an employer who is a good, consistent employer. It's actually, okay, what are you employed for? Okay, and can we make the adjustments to that role so that you can continue with that job plan? Okay, and that will consist of cognitive factors, emotional factors, physical factors, and sensory factors. Okay, can we do that? Does the employer know? Will they allow us to do that? So constant dialogue. Big in this is environment. Environments are absolutely ginormous in this. So, for example, a couple of folk who worked in a bank and a supermarket, you know, really, really busy, intense environments where multitasking is required. I refer to the chap who was heavy equipment in a factory. You know, again, the noise was massive. Couldn't concentrate, therefore was making mistakes, therefore was dropping things, therefore was at a risk. Okay, can he do that job? Can he do it in a different part of the factory? Those are the negotiations that go on. So you're going in as a therapist, as a professional, so you will at some point be having to speak with the first line in the employer's setup, which is usually human resources. And thereafter, there's another layer, which is occupational health. So it depends on the resources of your employers as to who you're dealing with first. Some people I just deal with HR. Some people I actually deal with Occy Health. And it's the health thing right there. It usually goes to an occupational health nurse or an occupational health physician. And if you like, I'm going in and what I'm saying hopefully marries up with what they're saying. And then we can do something that's called reasonable adjustment. So under the Equality Act 2010, formerly known as the Disability Discrimination Act, and that's still the same in Northern Ireland, but over here it's called the Equality Act. His employers are required to make reasonable adjustments. In other words, they can't just hear that you've got a health condition and then say, oh, you can't do your job anymore. So under the law, they're required to make these reasonable adjustments. Now, reasonable means cost effective, it means resource effective, it means, you know, all kinds of things. And reasonable is you know, relevant to the size of the employer, for example. So if you're working in a bar, the reasonable adjustments might not, at their disposal, might not be the same as working for Sainsbury's or something like that. So again, it's worth bearing in mind. But you know, we do hear of cases where people are discriminated against because of their health condition. That does happen, and it's not ideal. But if you've actually, as the lady earlier on says, I've told my employers about my condition, they then are required by law to act. Whereas if you haven't, because you might be afraid of discrimination, or perhaps you don't have the insight or just don't want to, it's a difficult position to be in. But you know, you can still use this legislation to guide you, as can professionals. There's a Q&A at the top, I think.
Yeah, so the next question, Alex, we can answer live, and it comes into the last slide, doesn't it, about the I think is the next slide on money. We cover money.
Yeah, it is about money. Yeah.
Yeah.
So,
yeah.
Is that in your occupational pension though, Elliot? I think that's really worth me knowing, because pensions are very complicated areas. So see if we can answer it in the next slide. Okay. Okay, amongst, so if employers, if you like, exhaust their reasonable adjustments, so there is another area that's provided, and it comes under government as opposed to employers necessarily, but again, there's a negotiation to be done, and the employers should be leading on this, is the Access to Work scheme. So this is a scheme that will allow people with a disability to remain in work. So for example, I work with a number of people, a gentleman that I know who is able to get taxis to work because of this scheme, so that he can continue working. And that's because he has an epilepsy, and that's because his epilepsy makes him subject to having seizures on public transport, for example, which of course is not safe, but he's a valued member of his employers value him. So actually it was agreed that this would happen. Another lady who has cognitive impairment, who works in a supermarket, is a shelf stacker. The Access to Work scheme was used to provide her with a PA at work to keep her on track, to keep her concentrating, and to keep her engaged in a role that she really, really loved. So again, all of these things are available, and there's a process that's quite clearly documented on gov.uk about this, and we should be following them. Again, talking about ideal work process. So we've got education, we've got adjustment, and now we've got transition. Because in the very first slide, I spoke about actually sometimes it might be a relief to continue to finish work, but we've got to think about the financial consequences of that. Now, okay, as Elliot has alluded to, there's pensions to be considered here. Now, the gentleman that I referred to earlier on, who's self-employed, because he was self-employed, he paid into a pension of his own setup. And what we did was he then started negotiating with his financial advisor. Again, it was an ideal setup as to when he could draw on his pension. So that was a self-employed, and because he was going to draw on it, he wasn't going to transition to employment support allowance, because employment support allowance is in lieu of an income and pension is considered an income. So he didn't draw on that, but he could take PIP, personal independence payment, because that is not about your finances. That's a benefit for your health condition, and it's not in lieu of income. I hope this is making sense so far, because sometimes I get very confused. Okay, if Elliot, you are talking about an occupational pension rather than a private pension, I don't know the rules for private pension, but private pension would be considered, I think, an income. So it's about getting some advice on that, I think, some really, really good advice on it. If you're talking about an occupational pension from your employers, such as the one that I pay into, the NHS, what I would be doing is, if I had a health condition that was going to affect my ability to work, and eventually I might have to give up work, this process, if you like, that I'm talking about works in your favor, because you need to go through that process in order, if you like, to allow your employers to say, we cannot employ you anymore, therefore we're going to medically retire you, so that you aren't leaving yourself with a whole load of loose ends.
Okay, so Elliot's working for a corporate company, just using the pension that was set up when joining. So that's the occupational pension.
So it's the occupational pension. So Elliot, you know, if you are noticing little red flags, then if you have told your employers about your illness, or you've developed your illness, by the way, whilst you've been working, because by the way, you can still use the Equality Act even if you've developed your illness whilst you've been working. So you don't have to tell them right at the beginning, because you often don't know necessarily. It's about now kind of going through this process. How do I go through this process now, and get the evidence that you need to determine what you're going to do next? I hope that makes sense. Getting back to this, monies, we have to think about them. We have to think about them, and as professionals, we have to think about them when we're working with people that we're working with. And again, I'll come back down to it: sex, drugs, money, work, all really emotive subjects, but we have to be brave and we have to ask about them. And people are often quite, phew, I'm glad you asked me about that, because often you can then find ways of helping people through that process. It doesn't necessarily fall on the OT's shoulders, because we're not experts in money, but we should know about it. We should know about the impact on our patients' lives. So we need to start building layers of evidence that will help our patients and their families apply for benefits, ESA if appropriate, if not, be considering PIP, and anything else that they might be entitled to. And I think sometimes as a professional or as an OT, you might overlook the importance of your functional assessment of an individual, but it's really, really important, because it adds a layer of evidence. So a lot of the HDA colleagues out here might work with wonderful people, but they'll also work with doctors who might provide a letter which says, this person has Huntington's disease. It doesn't actually comment on that person's function and what they can do and what they can't do and what the problems are. So it's really important. Negotiation, this goes on. So I don't know, again, for those people that are listening, again, professionals, occupational therapists, all of this takes time. And it might very well be in the community neuro rehab team you're working in as an OT. It might very well be that, you know, one of the things is that you have to get in and out within 6 sessions. I'm going to tell you now that this takes a heck of a lot more time than that. And you need to set your expectations with your patient, with your family, and also perhaps go back to your employers and say, yeah, actually, I'm going to need more time working on this. And then I suppose finally, if a person has successfully transitioned through this process, which is really difficult for everyone, but particularly for the individual, because we cannot underestimate the importance of the work role. Most people want to work. Most people consider themselves, when you say to somebody, hi, how are you? What's the first question that you ask? You say, what do you do? And it's usually about your work. And it is usually about the way that you identify. So this is so important. It's the continued importance of a work role, whether it's paid or non-paid or voluntary or just about occupation. And we know from all of these webinars that we've been discussing the evidence that purposeful and meaningful activity and structure and routine is key for the HD brain, key. So I think, Kirsty, you've got a nice story about a lady who you see, because it's like not necessarily associated with people in perhaps nursing homes, but you've got, yeah.
Yeah, I worked with a lady who had a diagnosis of juvenile Huntington's disease, and she came into the service that I was working in with quite a lot of behavioural difficulties initially, but actually one of the things that she hadn't ever done was worked, and when we explored that, and we were lucky to have available to us on site a organised support placement. She was really interested to do some work down there. She chose to do 2 mornings a week. I think they were mornings, because I'm now trying to remember, because getting out of bed wasn't the best time of day for her. She wasn't always keen to get out of bed. But she was doing some work in the garden centre. So a real working garden centre. She wasn't working in the face of the public. She was working behind, planting the seedlings, replanting them. And for her, as time went on, she was supported with staff, but it gave her a role and responsibility. And she got she had to clock in when she got there, and she got a small allowance from it. But the main thing for her was that opportunity to get up and to do something. It gave her a purpose to get up, and for her it was also seeing different faces. She really enjoyed that structure, and it was meaningful to her for the while that she was doing it. And I think that's the key. That's what we talk about, and we talk about for HD, but I think I think about myself and think about family members, having a purpose is really important. And that's, I can't appreciate not to have that, to have that work role. So it's finding a meaningful activity, a meaningful purpose.
Yeah, definitely. And of course, we know from things like, apathy, we haven't got any drugs for apathy. It's big in HD. And so again, structure and routine and a role really helps with that. And, it's hard to get the hook in at first, but then once you do, then again, it might flow a lot better. And again, it has knock-on and domino effect on mood and behaviour, all those kinds of things. So
I think the other thing is, it doesn't have to be massive. The example I've given you, we were lucky to have the resources on that site. But actually, we've said all along just how important that routine is, to get up at the same time of day, to have the same structure of you're getting up and maybe the first thing you do is get dressed to go and have your first cigarette of the day, and then you come back in and you get showered, and then you have your have your breakfast. We can't emphasize enough how important that structure and routine is with Huntington's disease. And the meaningful activity could be, at the moment, you're going out for a walk, or watering the plants, or getting in the garden if you're lucky to have a garden. It's thinking outside the box of going back to what's important to that person, and what's interesting, what's of interest to that individual. We talk about in care homes settings, we talk about person-centered care, but at the core of what, as occupational therapists, we're really interested in truly what's important to that person, because we'll be pulling on those resources in our treatment, in our interventions.
Yeah, absolutely. So now, we've got a whole kind of network of people via the GPs as well. So for people in the community, social prescribing, those kinds of things, which again, that's their role. Their role is to help you explore those kinds of things, just exactly in the same way that you've been talking about. I'm conscious that I don't know what time it is, Kirsty, because I've not been keeping a timely time.
Yeah, we've 1:15.
Oh, okay, we're doing okay.
We've got time.
Okay, I'm conscious of, obviously I've been speaking about people in work. There is a whole kind of different process and groups of professionals via the job centres for people that are unemployed and are looking for work. And obviously then that is then that's also part of the benefits system in and of itself, which I know can be quite torturous for people. But again, getting back to your lady who keeps going from job to job, it might very well take the pressure off there if she can get in and get understanding via disability, because there are disability employment advisors and job mentors within that setting, who can, through work placement assessments or work assessments, decide where you might sit in the system so that you feel less pressure to look for work, but can still actively look for work. And again, it's worth, as professionals, us knowing about that and helping our patients and their families navigate that. I think that's kind of all I wanted to say, because this was more about work specifically.
Okay. I think, Alex, listening to you speak as an occupational therapist myself, but not worked with people in the work, I'm scribbling down notes. There's so much to understand. Never mind for a family member or someone with Huntington's disease. So your knowledge is just huge.
But I then rely on folk in the HDA to kind of be up on the legislation and stuff like that as well, and other organizations, because literally it's huge. It's absolutely huge, but it's really important that we kind of understand the basics. So right, I think that's it, folks.